Hi, my name is Kendra, and this is my presentation on the 2009 H1N1 pandemic. So, some background information on H1N1 is that it's a respiratory disease caused by an influenza virus. It was known as swine flu because of gene similarity to a strain found in pigs, but the two are actually different. Scientists believe that reassortment causes the different strains in the two different types of viruses. Symptoms of H1N1 include fever, cough, sore throat, body aches, chills, similar to that of any flu. This pandemic mostly affected young people, for a third of those 60 years or older had immunity to it, and this is thought to be because they were exposed to a type of flu at a younger age that had a similar genetic makeup to H1N1. This pandemic affected more than 214 countries, and at least 18,000 deaths are confirmed. However, there are around 200,000 speculated deaths. And in October of 2009 is when the vaccine became available, so relatively quickly after the initial outbreak. Alright, so the issue was in 2009, the H1N1 virus was highly contagious because of the fact it was communicable. A strength was the vaccine was developed within months of the outbreak. A weakness was that it traveled fast and infected many people before a treatment was even available. Opportunities include improving preparedness for future pandemics with the lessons learned from this one. Threat includes virus latency, which increases likelihood of transmission because some of the symptoms did not appear for weeks. During this time, asymptomatic individuals have the ability to transmit to healthy individuals. The main organization responsible for control of the pandemic was the World Health Organization, which aimed to provide public health information and improve overall population health. One of the core issues with this pandemic was that research showed H1N1 was a quadruple reassortment virus, which meant that it contained genetic makeup from 4 different strains. The latent phase presents higher rate of transmission because if there are no symptoms, people who appear and feel healthy can be carriers and spread the disease. And there are also communication issues between health professionals, public health officials, and the general public. Federal sources encouraged vaccination, but it was in short supply when it first was developed, which caused an overflow of patients demanding treatment, which then put stress on hospitals and healthcare providers. The image on the left just shows how the quadruple reassortment occurred from the 4 different strains of the original viruses. The case solution came with the development of an effective vaccine, which was available 3 to 6 months after the initial outbreak. The health belief model can be applied in this case in terms of perceived susceptibility, cues to action, and perceived severity. Susceptibility happened with the fact that the virus was highly infectious, which pushed more people to get vaccinated because they believed that they were susceptible to getting infected. Cues to action include people experiencing symptoms or watching the news and other media that could alter their outlook on the severity of the issue, and also healthcare provider recommendations to get vaccinated could push people to do so. Third, perceived severity includes individuals that are more concerned due to the death rate spike, how it affects their families, etc. And this pandemic affected such a large amount of the world that people began to view it with more seriousness. One alternative is to improve communication. The back and forth between research data, public health informants, media, health providers can all get misconstrued, especially in the case of a pandemic, and there needed to be more efficient methods of information transfer in this time. Secondly, continuing education programs for proper prevention practices is important because since the virus was easily transmissible, encouraging safe health practices like hand washing, staying indoors, social distancing are all vital to decrease the global burden. The first recommendation is to create pandemic preparedness plans for future outbreaks, and this includes quarantining, social distancing policies, and recommendations for individual preparedness. Secondly, encouraging vaccinations to protect against the consequences of communicable infection is crucial, and disease detection and surveillance, and creating herd immunity. The action plan began with first identifying the virus and the affected demographic, which is the base phase. Secondly, carrying out preparedness plans, which would take about 3 to 6 months, and this includes social distancing, proper sanitation, wearing PPE when necessary, such as gloves and masks. Thirdly, conducting research, testing, and developing a vaccine. This could take anywhere between 3 to 6 months. And fourth, encouraging the population to get vaccinated to create immunity and eventually eradicate the pandemic, which could take 6 months or greater, depending on the severity of the virus. In this case, it was about 6 months. I believe that the 2009 H1N1 pandemic was not as severe as it could have been, and although there were many deaths, overall population health remained fairly unharmed. And if the virus had a quicker mutation rate, a vaccine would have been extremely difficult to develop. Luckily, this was not the case, and a vaccine was created relatively soon after the first outbreak occurred. Even though this pandemic had a clear solution, this may not be the case with future outbreaks. Pandemic preparedness must be improved in order to effectively decrease the disease burden.